we've come from and the importance of good science in making the decisions we're going to be making over the next couple of decades. An example is this one patient who is a 60-year-old female who has a 6/12 cataract, not a great view of the disc, pressures at 31, and the questions that we would have asked 20 years ago is, do you treat this person for glaucoma, do you not? If you do, what do you treat them with? How do you treat them? And what information do you need to make an intelligent decision? 20 years ago, we were using anecdotal medicine, and the real value of the multi-centered studies is today we're able to use sound science, not a few patients here, a few patients here, retrospectively studied. The importance of multi-centered studies is that A is a careful study design that minimizes bias, not a retrospective study where there's so many problems involved with who got treated and who didn't. Additionally, it's not a study where you look at a small sample size. You have to have an adequate sample size so that you have the adequate power to answer the question that you originally posed. You have to use your resources efficiently, especially nowadays with little money available for anything, let alone healthcare. We have to understand how to best utilize our money. The data collection is good because you have to force people to come for various time measurements. You have to analyze what data you need a priori. And in addition, you have to think of data safety and monitoring. And a good example was the mitomycin C dose response study that we did in Arvin almost 15 years ago, in which we stopped the study because one of the groups, the group that had the longer time and higher concentration of mitomycin C, ended up having more complications in a mass fashion. We always think of studies in glaucoma as having a goal of a pressure under 21. None of these studies have that kind of a goal. Basic goal is quality of life and visual preservation. Some of these were fairly bold. EMGTS was the boldest because it took people who didn't have any glaucoma, who had glaucoma, and randomized them to no therapy. Did therapy ever make a difference? Two of the studies had medicine versus surgery, medicines versus observation. Lasers have been involved in two of the studies. So we have a good sampling of different stages of glaucoma and different kinds of therapies. In addition, what is the goal? What was their endpoint for pressure lowering? And they were all different. The best really was a collaborative initial glaucoma treatment study that really dealt with a pressure, visual field, patient's age, sort of a George Speight, Ivan Goldberg kind of idea of how you should treat a patient. Let's look at some of the basics. The first really good multi-centered study, this is one-centered study, but it was from Baltimore, my hometown, is the Baltimore Eye Survey. And up until then, nobody had any idea about changes in different races, the development of glaucoma, factors that were associated with glaucoma. And when this study was first started, we felt that everybody with a pressure over 21 should be treated for glaucoma, even having surgery, even if they had normal fields and discs. And there's no such thing as normal tension glaucoma. So the question that you have to think about before going on is, what are the racial differences that we see? Indian eyes, American eyes, Japanese eyes. For disc prevalence, mean IOPs. Here we dealt with blacks versus whites in Baltimore. And think to yourself, I'll give you the answer later on, what percent of glaucoma has IOPs on a screening visit that's under 22? An important difference of this study than the first major prevalence study, which was Framingham, was that IOP was not a risk factor, or was not a definition of glaucoma. It wasn't that everybody over 23 or 24 had glaucoma. But this was really the study that set the stage for the Arvind, Andhra Pradesh, the Chennai studies here in India, looking at this visual fields, but none of them looked at IOP as a sole criteria. The study found that there were definite racial differences in the prevalence of glaucoma. So when you think about it yourself, Indian eyes, perhaps different parts of India if you have the same diagnostic definitions, may have different prevalences of glaucoma. This is a very important difference. Additionally, 50% of those screened who had pressures under 21 had glaucoma. 50% of the glaucoma, had pressures under 21 on screening pressures. Very important. Low tension glaucoma, which we now know is very prevalent, was hard to think about at that time. In addition, we don't want to treat everybody with high pressures because 3/4 of those with pressures greater than 26 never had field loss within the period of the study. So in essence, it's the first population-based study. The definitions did not include IOP, found racial differences, and found that people in the normal range actually had glaucoma, and that many of the people who had higher pressures did not have glaucoma. So as we've now learned, IOP per se is really poor screening for glaucoma. So the take-home message is that we really have to develop better screening methods and methodology for detecting glaucoma before people go blind. The second big study that came out was the glaucoma laser trial. This was started by somebody in private practice, a guy by the name of Hugh Beckman in Detroit. And the reason it was studied was because there was a lot of anecdotal data at that time that lasers didn't do well. People with laser surgery don't do well. Only a third do well at 10 years. Why even perform it in the first place? And Hugh's question was, well, really, most of the people in the original studies were people with advanced glaucoma who'd failed medical therapy or failed other surgical therapy. Perhaps if you got somebody early in the course of the disease, there would be a place for laser therapy, or there might be a place. So here you have a 64-year-old with real glaucoma that's early, and the question is, what do you do first? Do you do medicine first? Do you do laser first? Well, what should you do? And I think the study really, although it's overlooked, really gives you some real answers. So the question was, what is the safety and efficacy of argon laser therapy in newly diagnosed, never treated primary open-angle glaucoma? And these patients were compared to individuals who were treated medically. 217 patients were either randomized to laser first or medication first, and they had a step medication therapy. The target IOP, not success, but the target IOP was 80% of baseline IOP. So if you started out at 20, your target IOP would be 16. Obviously, they had to have higher pressure, but that was the idea. If you look at the results at the 2-year follow-up, and it was confirmed on the 7-year follow-up, amazingly, people who had laser first did better than individuals who had medication first. Almost a half were controlled at the end of 2 years on laser alone. Everybody in the other group needed therapy, and 2/3 of individuals needed more than one medication. And as all of you know from my lectures, the more medicines you use, the less likely they are to use it at all and be adherent to therapy. So the basic idea was that here 3/4 of the people were controlled on one medicine alone versus 2/3 needing more than 2 medicines. So the results are that people did better, their visual fields were better, their discs were better, and their pressures were better. So this is from the 7-year follow-up that was published in 1999. Take-home message is, think intelligently, don't make rash decisions, and it may be that laser therapy does have a place as an initial therapy in all of your glaucoma. I think that it probably does. If I had glaucoma, I would probably have laser therapy because I'm fairly non-compliant with my medicines. And the next important study was a 5-year-or-so treatment study. This is at a time when IOLs were first coming out. Filtering surgery was just moving away from Shea and Holt procedures to trabeculectomies. And the question was, does antimetabolites really make a difference? And so you have a person who has pressures of 45 on maximally tolerated medical therapy, who definitely needs surgery. They have field loss. They've had cataract surgery in the past. Does using an antimetabolite increase the risk of a suprachoroidal hemorrhage? Think about that in the audience. Think if you would say yes it does or yes it doesn't, and I'll give you the answer in a minute. Well, Well, the principal aim, again, was to see if the use of 5-FU, or the first antimetabolite that we really used, was both safe and effective. And these were AIs who did not have neovascular glaucoma, but who were either aphakic, pseudophakic, or a prior failed filter. And as you can see, that the success rate of those eyes who had 5-FU was much better than those who did not have 5-FU, but there was a cost. One of them was corneal epithelial defects. They almost looked like birdshot, like somebody had pellets that was sort of the cornea. But this is transient, and it had to do with the 5-FU disrupting the corneal epithelium. So that's how I get into the ocular surface disease, Satya. You were wondering how I was going to mold in. Wound leaks were more common, but this was statistically significant. Late blood leaks were also very common, 1 out of 10 versus 1 out of 50. And endophthalmitis was not statistically different, so there was slightly more, but not statistically different. In answering to the question of suprachoroidal hemorrhage, the answer is no, yes, there was a correlation between the baseline IOP and the development of a suprachoroidal hemorrhage, but there was no significant difference between those who had 5-FU and those of the control group. Well, obviously you'd say then you must lower the patient's pressure with mannitol before surgery, and there's no data to substantiate that. It just looked at baseline IOP and the rate of this complication. The next important study that I'll end with is the ocular hypertension treatment study. And here you have somebody who has a pressure of 25, thick corneas, normal fields, and a disc hemorrhage. Should you start therapy? Well, the answer is, and we answer this with the OHTS study, is that people who have disc hemorrhages who are ocular hypertensive are 6 times more likely to develop glaucoma, but only 13%, or 1 out of 8 of people with disc hemorrhages end up with glaucoma. So, yes, they're more likely, but not everybody does. In fact, most people don't. So here it was to evaluate whether or not medical therapy really made a difference in ocular hypertensives. Was it safe? Was it effective? Could it postpone the development of glaucoma? Look at some of these examples of a 60-year-old person who has pressures of 28.1 cups, corneal thicknesses of 600. What's the risk of glaucoma? Think to yourself, give me a number. It turns out to be about 2% in 5 years. So even though the pressure is 28, with this kind of cup-to-disc ratio and this corneal thickness, you're really unlikely to develop glaucoma. Well, let's lower the pressure a little bit, increase the cup-to-disc ratio, and lower the corneal thickness to a normal corneal thickness. You're now going up to 7%. So you've tripled the rate of glaucoma. But still, 93% of people won't develop it with those parameters. Well, now we're making the corneal thickness even thinner. Same cup-to-disc ratio, same pressures. What's the risk of glaucoma? Think to yourself. It becomes 1 out of 5. So by just changing the corneal thickness, we've done that. Finally, if you've changed the cup-to-disc ratio but keep the cornea thin, same pressures, what happens? And 1 out of 3 develop glaucoma. So corneal thickness and cup-to-disc ratios and pressures all correlate. Corneal thickness, which we didn't know about a decade ago, really made a huge difference. One of the important things that came out recently within the last 3 months was what happens at 10 years. And it turns out that individuals who in low risk, medium risk, and high risk, irrespective of the risk, their risk of developing glaucoma is doubled if they aren't treated of having field loss. So 21% of glaucoma patients who were treated developed problems as opposed to 42%. In essence, let me conclude with the fact that the multi-centered studies were important. They have helped us answer questions. They've helped us solve very difficult problems. And more well-constructed studies are needed to answer the questions that affect us globally and you in India. Thank you.